Welcome to Vein and Lymphatic University. Today, we have a very interesting case of a iliofemoral stent placed with a patient that has nitinol allergies. KJ got kicked off. We're waiting for him to come back. While we're waiting, I'm going to start our discussion and see what our panel thinks. Because most of the stents now are nitinol related, have you, Suat or Michael, run into a nitinol allergy? Michael?
So we know this topic very well. We are placing stents everywhere in the arteries, in the veins, but actually, I never saw a very severe reaction to nitinol. I think in theory there might be an issue, but practically I never saw it, especially with a severe reaction. Suat, I don't know what you think about that.
Actually, I totally agree with you, Michael. But I have one of my patients with May-Turner syndrome, which she is very symptomatic, and in her history, she has almost allergy to everything, and taking lots of anti-allergic therapies, cortisone therapies, but even from that situation, for example, one day she's not allergic to one substance, but the next month it can be changed for this lady. Actually, I stented, for example, her mother as well. She had a May-Turner related left-sided iliac vein thrombosis. We stented her mother. After then, she came to me, but we discussed this with the allergy department if we should stent these patients or not. But the allergy department actually they couldn't give me a guarantee that maybe at the moment she doesn't have a nitinol allergy, but it can be changed. So for this patient, actually, I decided not to stent this patient because if we have a severe problem after stenting, explantation may be much more difficult. So I decided not to stent, but now we will hear, I hope, a good case. But in my practice, it was like this.
So I believe KJ has written a paper on this exact topic. So I know that he's had an experience with it, and I've heard his presentation, so it's very good.
It is an very uncommon thing. As I agree with the discussants, I've seen a severe reaction only a couple times, and this is one of the cases that we're going to present that I'll show you all. It's a interesting case in that it was someone who I'd seen initially in consultation and was apprehensive about treating because of this kind of reaction.
I'm KJ Nagarsheth. I'm now the chief of vascular surgery here at St. Louis University. This is a patient I took care of when I was in Baltimore. It's a treatment of iliac vein stenosis in a patient with Nitinol allergy. Quickly through the case, this was a 37-year-old woman who had left leg pain and swelling as well as pelvic pain. She had a prior history of motor vehicle accident and a subarachnoid hemorrhage along with long bone fractures in 2015. She had an IVC filter placed at that time. It was a Bard-Denali filter. She developed airway edema subsequently, required intubation and removal of her filter. Since that time, she's been diagnosed with a Nitinol allergy. This was confirmed by immunology and rheumatology. She has long-standing pain and left leg pain and pelvic pain, as well as worse pain during menstruation. This was a duplex ultrasound that was identified in our office showing the compression. She's had prior endometriosis, pelvic floor therapy, all that stuff, pretty similar to what we normally see in this patient population these days. At that time, I had done a venography on the patient. There was concern for the stenosis. These are the findings we saw. We saw a high-grade stenosis of the iliac vein at that time on the left side, along with some cross-sacral collateral vessels, as well as an ascending lumbar vein. At that time, I told her I didn't feel comfortable placing a stent for her, and I recommended she get other assessments and other options, other opinions. She went to an outside facility and had a stent placed. Her symptoms improved for about 2 weeks after that stent was placed, then returned significantly worse. Repeat imaging showed stent occlusion, and the patient developed a rash on her left flank. I wish I had pictures of those. Those were on my old computer in Baltimore. We planned her for a stent explant and a bypass at that time with the assumption this was secondary to early thrombosis, secondary to a reaction to the nitinol stent. This is intraoperative pictures. It was a lower midline incision. We exposed the left common iliac vein and the IVC confluence along with the right common iliac artery, as you can see there. It was a wall stent. We performed multiple venotomies in the vein to remove the stented segment. This is a video. Let me see if it'll play. As you can see, Dr. Glavitsky described this. Multiple people have described explanting of the wall stents where you remove them strand by strand, and they come out like just a long piece of metal. And as you can see here, my former fellow taking that out. Once you do that, the vein is not very great. It's sort of disease, and then she still had the thrombus that had developed inside. The vein itself was not of good quality, so we decided at that time to circumferentially free it and do an interposition bypass. Not interposition, I'm sorry, a bypass around the occlusion, around the common iliac artery. So we dissected the IVC confluence and the common iliac vein. We divided the enlarged collateral veins that were still there with absorbable ties, used a 12 millimeter PTFE conduit and performed endoside on the common iliac and then the distal IVC to reroute it. 1 year postoperatively, her symptoms had still been resolved. Her rash improved with steroid use and a high-dose steroid taper, and all the other symptoms improved. She was kept on a DOAC for the occlusion as well as for the patency of this bypass. 1 year after, she's still doing better, and you can see the pre and the postoperative duplices here. You can see the flow on top of the artery in the bypass graft. So nickel allergies, overall, there's about a 10% incidence in the general population. Women are thought to account for the majority of these, and the incidence is about 14 to 20%. Sensitization is secondary to piercings, and that's the belief right now internationally, is that the number of piercings have increased in the population. People are getting things pierced that we never got pierced before, and so there are a higher rate of these nickel allergies developing. The risk for developing nickel allergy increases with the number of piercings. This was actually published data. The nickel allergy is a type 4 hypersensitivity reaction. It's cell-mediated hypersensitivity. Th1 cells secrete cytokines, which then activate macrophages and cytotoxic T cells and cause macrophage accumulation at the site. Most common forms are contact dermatitis and a tuberculin reaction. Autoimmune diseases can also play a role. So the symptoms can be multifocal edema, hives, urticaria. They're sometimes reproduced by placing a nitinol stent on the skin, but that only tells you whether or not you'll have a type 1 hypersensitive, or a primary dermatitis. This is the nickel content of stents that are available on the market. Majority of self-expanding stents on the market do have nickel in them in some capacity. Wall stent seems to be the lowest amount, and then the Cordis Palma stent has the lowest amount, about 10 to 15%. But many of the self-expanding venous stents that are out there, and even ones that were taken off the market, had about a 55% nickel containing alloy in them. So this is the workup we talked about. We look at cutaneous hypersensitivity reactions. We look at eosinophil counts, lymphocyte stimulation tests, and then we evaluate for cytokine production. This is all done with our rheumatology colleagues. This is a proposed algorithm for heavy metal testing and metal sensitivities, whether they have positive metal tests, symptoms or no symptoms, then whether or not the device can be removed safely, is it necessary? These are all things that play into the calculus of what should be done. And then oftentimes, if it is removed and it's a vascular device that needs to be replaced, we'll replace it with either autogenous vein or a PTFE. In conclusions, known metal allergies don't always correlate with clinically significant allergies, given nickel desensitization can occur. It makes it difficult to determine the amount of exposure someone needs to elicit symptoms. Stent explantation is possible for symptomatic patients, but you have to have a plan for revascularization if they need it. And May Thurner, you all know, and anteriorization and bypass are options for these patients. Again, I apologize for the delays and my technical issues, but I'm happy to take any questions. Thank you.
Well, thank you very much, KJ. I'm glad you mentioned the different stents and the amount of nickel, because that was my first question to you. The question that I have with this particular case, if the stent had not thrombosed, how would you have managed this patient? And when would you have pulled the trigger in terms of saying this patient needs to have the stent removed?
Yeah, so if the stent did not thrombose, we look on duplex ultrasound to see if there's layering thrombus forming, if there's anything abnormal. Has the inflow been treated properly? Because sometimes we see that sometimes the inflow has not been treated adequately in the common femoral vein or something like that, and that leads to early stent thrombosis. So if those things had gone on, we'd think this was more of a technical issue with an early stent thrombosis as opposed to an allergy. In this case, none of those issues were a problem because this was a non-thrombotic lesion from the beginning. And so it wasn't like there was synechia or anything like that within the vein. For me, I look at all those things first before pulling the trigger for anything major like a stent explant and a big open surgery. I think that's really important to rule everything else out. The other thing is I rely very heavily on my rheumatology and immunology colleagues. And I have the patients see them, especially if they develop a cutaneous rash or something like that after an implant. I usually have them evaluated by them as well, not just me treating them with a high dose Medrol pack or anything like that.
No, I understand that. But the question is, so they had a rash, the rash went away. You know, the question is, when do you pull a trigger? And I'm going to turn it over to Michael, followed by Suat. So Michael, the floor is yours.
Yeah, thank you. So first of all, great presentation. I think it's definitely important to highlight this topic, which is typically not on stage or discussed during Congress. So it's quite important. So again, as we discussed in the first minutes, I think we have to stage the reactions. You know, a reaction to some jewelries. Yeah, I don't see them as that severe. So it would probably not prevent me from putting a stent in such a patient. But if a patient really has a severe reaction like urticaria or any systemic reactions, I think it's a completely different stage. This I think. Therefore, I think a stage diagnosis reaction is probably the way I would go for it. So maybe your opinion to that. And the second question is, how do you work up these patients if they have a little bit more than a cutaneous reaction to nickel? Do some routine workup in these patients, and what kind of tools do you use?
That's a great question. So I'm seeing more nickel allergy than I've ever seen before, and I have patients coming in complaining of nickel allergy. So I have a sense of a suspicion when people come to me telling me they have a reaction to cheap jewelry. That's usually the most common thing. But that being said, now I'm seeing many more patients with things like mast cell activation syndrome and POTS and these other kind of diagnoses, especially post-viral syndromes. After they've had the flu or even after COVID, we saw a lot of this. I'm finding much more significant nickel allergy, more than just a cutaneous jewelry response in that population. So when they come to me with that constellation of comorbid conditions, I take it a little more seriously than in the general population of people that just have an issue with reaction. But again, I rely very heavily on my other colleagues in the school, and we do lymphocyte screening and other types of testing to make sure there's a real reaction as opposed to just a cutaneous reaction that can be treated locally.
Anything further, Michael?
Yeah, so I think a venous stent is something else in terms of indication than, you know, just a coronary stent. A patient with a myocardial infarction, you know, he needs a stent. Yeah, so I think this is also something we need to take into consideration when we plan for a patient with history of nickel allergy. Does this patient needs really a venous stent? So that's another point I would say. From a pathophysiology aspect, what we know is that typically around that nickel there's a titanium layer. So it does not mean that the nickel really goes systemically into the blood. So this is another point. And maybe my last point is just having a glimpse into the future. Bioresorbable scaffolds in the venous system are coming. At least 2 startup companies working on that, and this might be an option for these patients. completely avoiding nitinol in these patients if their severe reactions are documented.
Thank you, Michael. Suat?
Thank you, Lowell. Actually, congratulations on the presentation. It was a really nice case that we should also keep in mind. Just before your presentation, I mentioned one of my patients. She has allergies to everything, but because she has a May-Turner, I first planned to do it, but then we discussed with the allergy department, and then even they couldn't guarantee that maybe at that moment, if she doesn't have an allergy, but next month it can change. So for this patient, for example, since she is a very heavy allergic patient using a lot of anti-allergic medication, we decided not to do this procedure. But in your case, maybe if the patient, for example, reacts to medications like steroids and other things, would you still plan to do the explantation, or you should still go for explantation?
So the calculus that we had was this was a foreign material inside the patient. It had been placed relatively recently, so explant was not going to be as challenging as if it had been there for a long, long time, and we had less worry about injury to adjacent structures, which is part of the reason why we decided to explant it to remove this, because it was a relatively recent occurrence. If the stent had been there for a long time and was very incorporated, I think it would have been a much different story, and the risks would not outweigh the benefits in that case.
For example, your case was a Lowell stent case.
It was.
So did you had also experience with the new dedicated venous stents?
So I have removed Venovo stents, barred Venovo stents as well. And they're a little more challenging because they can't be pulled out strand by strand. And it kind of ruins the vein for any kind of salvage typically when I have had to remove them. So in those cases, I've had to do a bypass or some sort of interposition of some kind just to reconstruct the venous system, because otherwise the vein is not really usable. With the wall stent, sometimes it is reusable. If you make the nicks individually, you can repair each one of them with a Prolene suture, and then you can preserve the vein.
The interesting thing, KJ, if this patient just had a rash, first time, 2 weeks out,
Yeah.
what would prompt you to go forward?
I wouldn't. If it was just a rash and I saw nothing happening to the stent itself, I would not have moved forward. I think I would have treated that more as a dermatologic issue as opposed to more of a systemic issue. The other issue with this patient is when in 2015 she had a car accident, had a Denali filter placed, which is also a nitinol filter, and she developed airway edema subsequent to that. After that, she's been labeled with a nickel allergy. And she's been followed by people for these things, but she also had other comorbid things like mast cell and things like that. So she has a team behind her already, who basically told her not to move forward with stenting, and the patient still decided to move forward with it. Thank goodness not with me, but with somebody else. But she still decided because her symptoms were that significant.
I did not hear, did the Denali filter get removed?
It was removed right after she developed the airway edema and got intubated, because their working diagnosis at that time was this was some sort of reaction to the implant, because this happened very quickly after the implant, from my understanding.
Yeah, I was able to look up while you were talking the amount of nickel in the wall stent versus the others, and you're 100% correct. The wall stent only has about 15% nickel, and the rest of it, is a combination of alkali, and the rest of the others are at least 50%.
Right.
So,
And nickel is something we can't avoid it. It's part of our world. Stainless steel, the microphone in most people's smartphones is made from a nickel alloy. So it's really hard to avoid nickel. So that's why I'm sometimes very skeptical when people come to me with a nickel allergy, but they're talking on their phone, or that they have like a stainless steel bracelet on or something like that. Like I'm sometimes very skeptical of it, but at the same time, we are seeing more of it, and it's something that we need to know how to manage.
well, I would like any further comments. If not, I would like to thank KJ, KJ, congratulations on your new position. Congratulations on tornado warnings. And I would like to talk about next week. We're going to do an update on HIFU with Paolo Casani as the speaker. Anil Hingorani will be the guest host because I will be on location in Europe. And Steve Elias will be discussing, as well as Dr. Stalankowitz from France. So thank you very much. And thank you, Michael, and thank you, Suat. We'll see some of you next week.
Perfect. Thank you.